Well, everyone, after this dramatic start, I'm delighted to welcome a dear friend and colleague to give his presentation here on the clinical experience and best practices in functional radiosurgery. I know Tony, and he's Tony for me, as far back as residency when we both served on the staff, me, the resident staff, he and the technical staff at Mass General a generation ago. At that time, he was doing proton irradiation with Ray Gelberg. We went on and to be some of the early pioneers in LINAC radiosurgery. Tony went off to UCLA, a job that I too looked at some point. But we're both West Coast denizens. We both were, I think instrumental in making radiosurgery happen over the last 30 years. Then we diverged and took different paths. Tony went off to conquer the continent of South America. It is really one of the leading, if not the leading light in radiosurgery in Latin America. And more recently, I've been working here at ZAP. And it's so nice to sort of reconnect with old friends this way. And I'm truly excited to see what Tony is doing in the functional radiosurgical world, because that is particularly dear to my heart and where I think much of radiosurgery will be headed in the future. So without further ado, welcome, Tony.
Thank you very much, John, for the invitation. I'm very flattered for your nice words, and honored to speak to ZAP. ZAP is really revolutionizing functional neurosurgery, in my opinion, and obviously radiosurgery for the brain and head and neck. It was overdue, a machine that could be treating people throughout the world with an affordable price for everybody to have access to radiosurgery. As we see here, Brazil. Brazil is a country of 200 million people, 2 million people needing radiosurgery in the world. Therefore, Brazil is needing 57,000 people to be taken care with radiosurgery. This is per year. While in Brazil today, we probably do 2,000 radiosurgery cases. So there is an extreme need of radiosurgery in this country of 200 million people. There's also a need of linear accelerators. Linear accelerators in general to treat cancer, which is as important as any disease in the brain, they are not enough for the population as well. So they cannot fulfill the need of very developed machines, even linear accelerators to treat this population. So to have quality, we need to have dedicated machines for the brain. Radiosurgery is a major improvement in the quality of life of people, and actually has done a major impulse in neurosurgery. We see here that in the Department of Neurosurgery, well developed at UCLA, we see that at least 30% of the volume is treated with radiosurgery. Our group, Neurosapiens, is the group that I came to Brazil to develop to see if I could fulfill this need of radiosurgery in the country. Now it encompasses 10 states of the 26 Brazilian states. Approximately 3,000 neurosurgical cases per year are done by the Neurosapiens group. So we approximately could treat 1,000 cases per year, and today we treat 150 to 200 cases per year, even having a Gamma Knife, having a Cyberknife. And why is that? There is an extreme need of disseminating the knowledge giving the opportunity to the young to learn, and entice the neurosurgeons to refer cases for radiosurgery. Radiosurgery is a major complement to neurosurgery. It's not to take neurosurgery away, but to make neurosurgery safe, and to make functional neurosurgery safe. I have to talk with you about the best practices. And talking about the best practices for functional radiosurgery, I will take a little bit of my clinical experience that now I have disseminated throughout Brazil, working with the Redidor São Luís that has now more than 50 hospitals spread throughout Brazil. They have the volume of cases we need to treat patients, a large percentage of the patients that are in need of radiosurgery. We also have a research group. This research group now linked at UCLA to the major university in Brazil, USP, and to the Institute Door of Research that's part of the Redidor São Luís. So we are very well poised to develop radiosurgery to a very high level in the country. As an outline, I will talk with you where we are. Where we are in medicine in general, the competitions that we have, robotics, optogenetics, radiofrequency, laser, HIFU, and then we'll talk a little bit about radiobiology of making the lesions in the brain, anatomy, extremely important, and together with electrophysiology is a major part of functional neurosurgery. You need to know these to do functional neurosurgery, and talk about the diseases that really encompasses many of the diseases of the brain, chronic pain, tremor, Parkinson, dystonia, epilepsy, depression, entering in the psychiatric diseases, obsessive compulsive disorder, post-traumatic stress disorder, addiction, an important problem in the world now, aggression, obesity. All these can be helped by functional neurosurgery, and the radiosurgery is in the center of this development. Actually, radiosurgery was developed by Dr. Lexell from Sweden just to treat these patients. That's what he had in mind, but really with the imaging development, it became one of the major treatments in the brain for all tumors and vascular diseases. Well, the man, the Homo sapiens, used to live 40 years. This was for thousands of years. The survival of a Homo sapiens, they will die of infection in general. They'll die around 40s, their 40s, and we have their syphilis and cholera and all the infectious diseases that destroyed even the pandemics would occur here and bring the life expectancy down. When we solved this with antibiotics, we came now starting to die of the heart. Heart attack for my grandparents was the major cause of death, stroke, all related to vascular diseases, arteriosclerosis, poor habits of eating. And when this was solved, the pacemakers, now enters electricity here. The cardiologist dominated the pacemaker for the heart and taught us to use the pacemaker for the brain. And now we have very well-developed pacemakers. Even intelligent systems are appearing with remote control for the patient, remote control for the doctor, and rechargeable. They are going now for 25 years if you need. So they can go through the lifespan of elderly that have a degeneration of the brain, one of the diseases such as Parkinson's or Alzheimer's. Well, the reality is that the future, the Homo sapiens, has to dominate the genome. And there's a lot of investment in this, and we know that we don't know enough about this. The coronavirus, COVID-19, has been a very important threat to the humanity now in the 21st century, in the beginning of the 21st century, because we don't understand well how this replicates, how can we take care of this virus. So we need to understand and dominate and moderate this molecule, the chromosome, so we can indeed take care of several diseases. And here where we are now, we are implanting pacemakers and changing people's lives, but we can also change people's lives with functional radiosurgery. And this is something that we are getting to very fast at this point. Competition, where are we in the techniques that can modulate the brain? So if we look at the brain, well, we have indeed a network of chemical, electrical pathways that are extremely complex for us to understand at this point. Now that we are starting to see these pathways, we're starting to see what we believe that are the fibers in the brain, that are the axons crossing the brain. It's really a very, very complex network. It's a jungle that we could even compare to entering in the Amazon. We can see that how can we place a probe here and try to modulate only the cells that we want. Well, this is becoming possible with a technique called optogenetics. For instance, you can take from the membrane of this animal that is marine animal that is called by light. He reacts to light. He has channels that respond to light, and these channels open with light, so it moves, so it makes the animal to move. So if we take this molecule that opens this channel, and we can implant this molecule in the membrane of a neuron, then we can shine a light and actually stimulate a neuron. So it's a universe of cells now that we can shine different colors of light, and we can stimulate a neuron to fire. Well, this is extremely important because suddenly now we can, with viral vectors placed in the membrane of neurons, the type of molecules that we can stimulate. Well, in the technology level, we have the marvelous development of years of learning. This is being now accumulated more than half a century of knowledge in this machine. The Gamma Knife is embedded here. The linear accelerator is embedded here. The precision and the calculations necessary to treat a very fine lesion inside of the brain is now available with a precision that is definitely sub-millimetrical. So this is not to treat the whole body. This is to treat the brain and a little bit of the head and neck type of pathologies. So this is to focus the neurosurgeon, the head and neck surgeon can participate, but this is to add the knowledge of the neurosurgeon to the radiation therapy. The radiation oncologist, he is an oncologist, he's not a functional neurosurgeon. A functional neurosurgeon is someone that has a special personality and does special jobs. And over the years, the functional neurosurgeon developed radiosurgery, Dr. Lexell, developed the DBS, the deep brain stimulation, which are the pacemakers to the brain that are making marvelous improvement in patients, doing lesions with radio frequency, with laser, inside of the magnetic resonance, and the HIFU which is the high focus ultrasound, also is doing the same. We can see the lesion being made. So these are developments of functional neurosurgeons. These are people focused in technology, focused in precision, and have a brain that is accustomed to that. For example, Dr. John Adler, a neurosurgeon, has developed a CyberKnife for the radiation oncologists for the world. This is a machine that can treat the whole body with the precision of radiosurgery that we have in the brain, and also brought knowledge to the Gamma Knife. The Gamma Knife icon now can have imaging while we do this. So this is extremely important at this point, that we take all this technology and we can help the patients with diverse diseases. For example, the Gamma Knife, a device that was developed focus. That's where we all learn the basics of radiosurgery. The data accumulated over the years with imaging has been extremely important. For the first time, patients are really followed for 20 to 30 years. Patients that are operated on conventionally are not followed that long. They lose the sight of the surgeon, and the patients, we really don't know what happened to them. But now here with Gamma Knife, with radiosurgery, these patients are definitely followed, because once you change the genetic code of a tumor or a functional case, you wanted to follow this forever to be sure that that tumor will not grow, or that Parkinson's disease, whatever, will not return, or the tremor will not return. So we are always looking at these patients with the quality of imaging that we have today. Functional neurosurgery is really a small group of patients that benefit from this when we look at the universe of neurosurgery. So this is the 30% of a department of neurosurgery, and you see here that the functional neurosurgery is here approximately in the 5% level. The knowledge accumulated from proton beam, Gamma Knife, LINAC, general LINAC, variant LINAC in general, CyberKnife, Novalis, all these are being perfected over the years. These machines are extremely precise, because the mind for radiosurgery was on it. So it's not taking any linear accelerator and starting to do radiosurgery. These are my machines that are perfected for that, and we know that we are in a point now that we can trust the precision of this machine. And I have had the experience of all these machines, so I have seen now that this ZAP technology is encompassing everything I need to do functional neurosurgery. I think we all need to do functional neurosurgery. So what do we need? What we consider to be a best practice? You gotta have small collimators. You cannot do functional radiosurgery with a 10mm collimator. There where the complications come about. They focus a 10mm collimator in a trigeminal nerve that measures 3mm. You are obviously destroying everything surrounding it. And that is not what functional neurosurgeons do. Functional neurosurgeons go focus on what's necessary. So we have used 3mm to 4mm collimators. It is difficult to measure the output of a 3mm collimator, but the technology is always improving. We are getting there, and I show you that that's the case. We need a sharpest fall off. Here we have a 3mm collimator, and we have a 4mm collimator of a Gamma Knife. This is a 3mm collimator of a Novalis, a linear accelerator. As long as you have dedicated teams and people that are focused on precision, then you can achieve good work with a linear accelerator. These are the profiles then of the ZAP that really approaches, or is better than the Gamma Knife in certain instances. Here we have X, Y, and Z. It really depends on where you measure your profile. But here we see that we have what we need to treat a lesion that is located measuring 4 millimeters and nothing beyond this, or making a lesion in the brain or radiomodulated the brain very precisely. So we have indeed an adequate functional radiosurgery device in this machine. So it's progressing with the size of the collimator is extremely important. If you look at the hypothalamus where we operate, hypothalamus measures 4 millimeters. So I will discuss that a little bit. The STM measures 5 millimeters. So how do you modulate a group of neurons sending radiation to change the DNA, and you are doing everything surrounding it? You know, this is not cancer that you have to radiate beyond the 2 millimeters margin. There's no 2 millimeter margin. There's no margin. We can't have margin in functional neurosurgery. And we can modulate here. Here in this publication, we show quite nice that we have production of tyrosine hydroxylase, which is the precursor of dopamine, L-DOPA, that the patients with Parkinson's disease need. So we have a future ahead to study this. Well, neuronal activity, we cannot stimulate the neuron with radiation. We know now that if you do a PET scan immediately post-radiosurgery, you have glucose utilization increase. We can cause seizures, firing of those cells. We can then immediately, acutely touch the cell's function. Now, if we touch the function of the blood-brain barrier, we can open this, and this open 2 months, 3 months after, we can have here a leakage of gadolinium because the blood-brain barrier is open, and a completely disappearance of a small astrocytoma here because we are killing the glial cells related to it, you know, the astrocytomas, so they are glial cells. And we can also destroy neuronal cells. If we focus very high radiation, we can do a necrotic lesion and destruction of cells with high energy. And here is what Dr. Lexell, the inventor of radiosurgery, he was trying actually to imitate a radiofrequency lesion that was very commonly used at those times. And here we see a lesion that was taking a little bit of the internal capsule. So to show you the importance that when you are doing a palamotomy, here is the thalamus, you want to enter only in the thalamus. At this time, imaging was not quite good, the surgeon was not well trained. So it's extremely important that we have a person that knows how to do this. And actually, this is the radiobiology view, acute evolution, and then the lesion that comes finally with the early, delay, and late stage of a radiosurgery lesion. Well, radiomodulation. We are talking about radiomodulation. At some point, I used to call this restoration of the brain with radiation, radio restoration. But here, I think this term is definitely a better term. When we approach the brain with radiation, we have a universe of cells that we deal with. And we can make a lesion, a ischemic lesion, depending on the high dose you give. If you wanted to interrupt the pathway, very high dose, we'll do that. If you wanted to make a vascular modification in the wall, it's a radiomodulation of the wall of this vessel, then it's dose dependent. We know that. We showed that in the 90s. And we can accumulate, for instance, collagen in the periphery of the artery because we have modified the function of the cells to a point that we'll have an obstruction of that vessel. And this is the way that you make a ischemic lesion in functional radiosurgery. We can modify the firing of the cells. This is a hamartoma, a hypothalamic hamartoma with the vision passing through here. With the hypothalamus, with all the hormones here, we can be very focused and precise here. Cannot use any machine. You have to use a dedicated machine to do this type of work and cure a kid of 3 years old. Experimentally, we showed that. Here is a Kindle model of epilepsy. We have the focus here. 2 months later, that focus no longer exists in the animal. So indeed, we can modify function of cells with radiosurgery. Trigeminal neuralgia, this is the most common functional case. Why? Because it's safe. We have water. We have to worry about this brainstem here. So as we go out, we are taking only the nerves. So people that don't have the precision to get close to the brainstem keep on moving out, and the results should be about the same. Maybe we have shown that for us it's not quite so. Others say that it is. What we are causing is really a demyelinization of peripheral nerve. We see here, but the myelin in the entrance of the nerve is really more sensitive to radiation. So there you have an effect that's a little bit better than if you do only on the nerve. So I already insisted on this. We have a dedicated machine. It's extremely important. Busy departments treating 40, 80 patients a day should not be doing radiosurgery, functional radiosurgery, and radiosurgery for that matter in the brain in general. But functional neurosurgery, definitely not. It's dangerous. You know, I have seen cases that 3 patients in a row being hurt to death trying to treat trigeminal neuralgia in a busy day. So this is not to be done, definitely. Functional radiosurgeons, I have said that they have a mindset of improving function. They don't have a mindset of destroying a tumor, for instance, as the oncologist should have with medication as well as radiation. We want to change the function, and we go change the function very focused, arriving very close. As we go closer with our ISO center, with extreme precision, we have slightly better results, and we have shown that. And in the literature, it was a major impact that our group did with radiosurgery. And we showed that when we arrive to 80 to 90 gray, we end up leveling out the quality of the numbness that you have. If this is patients mention it, this is not bothersome to the patient. We have shown here that indeed, when we bring the focus closer to the brainstem and we have a slight enhancement in the brainstem, we have a statistically significant better result. The control of pain that lasts longer and comes faster for the patient. So this is extremely important that you can bring your target precisely where you want. And here, if you want to, for instance, to modulate the nigra or to make a lesion in the nigra, here what we are trying to do here is show to you with immunohistochemistry, ZAP-X, that how the lesion is formed. We have a modification, we have a vascular influence, and neuronal and glial influence, and finally you have a lesion. You have a scattering around. This is extremely important. That's why it needs to be very sharp. Notice here that we have indeed a change in function of these cells with production of growth factor in that region. It's just a repair reaction. Now, moreover, we can, when we turn the radiation, we can indeed produce ZAP there, serotonin, tyrosine hydroxylase, and glutamate. These are radiation effects and neurotransmitters, and this has to be extremely precise with very, very, very small collimators so that we don't change the function in the brainstem of other very important structures. For instance, the STN that's in this region can be measuring only 5 millimeters, will be completely destroyed or completely manipulated in the wrong way, because we have irradiated not only the motor part of the STN, but also the cognitive part of the STN. The precision is extremely important. Frame or frameless, there are the ones that believe in frames. I have nothing against frames. I think frameless is more comfortable. I use both techniques, and I don't have anything for or against. Some patients prefer to have this done than stayed in the frameless machine. So this is there to be chosen, and nowadays, even this machine, you can use it frame or frameless. Now, 1 millimeter of is allowed in some functional cases, but outside of the brain, right? Inside of the brain, we cannot do 1 millimeter. 1 millimeter is too much inside of the brain. Here, for instance, a senopalatine ganglion that has only bone and soft tissue surrounding it, yes, you can have 1 millimeter lack of precision, but that's not the case when you are really using inside of the brain. And here you can use X-ray, MRI, or CT scan to target. Well, some provocative applications, for instance, facial spasm. You can decrease the facial nerve function with a proper dose of radiation. The Italians have done this. Tinnitus, as long as it's early on, you can improve the patient. After it becomes central, it will not work. But here is, now we can see these nerves with a precision that we can treat glossopharyngeal neuralgia is likely caudal than this. Here we are not seeing the glossopharyngeal nerve, but you can start to approach diseases that before are extremely difficult diseases to treat. It takes a posterior fossa operation with risks of life in some cases. So this is really a very serious problem that we have to deal with. Well, epilepsy, another one. I showed this case to you, right? We have an extremely precise dose distribution only inside of the hamartoma, because you want to modify the cells. We don't want to destroy them. We want to stop seizures, and we do stop seizures in this case. Total control with 17 gray. That's why I treated that 3-year-old patient. Here, 17 gray. This girl had edema, had steroids. So this volume is way larger than this volume here. So this is extremely important. What do we really need to treat? As imaging improves, and we can see the focus very well with magnetoencephalography, with the PET scans, we will be able to decrease the volume and treat seizures more precise. Right? Here's another case with completely controlled from the group in Mexico City from Dr. Salles, showing a total decrease in size of hippocampus with 18 gray 2 years later, complete control of seizures. So this is important that we focus studies on these. Dr. Nick Barbaro has done a very nice trial, Rose trial, and what he showed is that he did control seizures with radiation, with radiosurgery, but not better than surgery. So it's not a failed trial, it's a trial that shows that surgery is better, and that's common in many, many applications that we do radiosurgery, including trigeminal neuralgia. Classic non-coplanar arcs, this is how this machine works. It's avoiding as much as possible repeating radiation in the brain, so we don't spread radiation throughout the brain. Patients frequently ask, well, will I lose the hair? No, you're not going to lose the hair, because it's so little that comes from outside. You see the concentration of radiation very well. This is important for OCD. OCD has evolved. We are still studying which part of the internal capsule that we can focus on different symptoms. OCD, we can have a washer, we can have a mathematical focused mind that is always calculating. We can have very intricate thoughts, and they are occurring in different parts of the brain, in different parts of the internal capsule. It is extremely important, the precision. Here we have a Gamma knife dedicated to this type of work. And when they change the model of the Gamma knife, then the isodose lines start to meet in the center. One patient had a cyst and actually died of that cyst. And so it's unacceptable to take a person that has obsessive compulsive disorders and risk their life. So Dr. Jan Padek did a very nice plan, a 10-shot plan, but this is not how the majority of the world does, but to be sure that we don't have isodose lines in the center. The volume, the 12 gray volume, is extremely important to be paid attention in this case. Deep brain stimulation is definitely a great technique, but capsulotomy with radio frequency or with Gamma knife has better results. With radiosurgery has better results than long-lasting results. This is significant here. These are very few patients because there are few patients operated in the world. What is extremely important also, here we go, is 1/5 of the price. And the patient doesn't have to return to the doctor as frequently as he has with the DBS that brings erosion, infection, pain, and several other problems that functional neurosurgeons deal with when they implant a patient with a pacemaker. As we use 120 gray, 150 gray, these are extremely high doses. It's important to know that what you are doing is really this. And now we can have that information with the ZAP technology. I think this is a major improvement in what we do. It's something that we are very happy that's happening. We have been looking at where we need to make these lesions to be able to understand. For instance, this is a lesion, a capsulotomy in the base close to the accumbens. Now everybody's trying to do accumbens for addiction, for even obsessive compulsive cases. So we studied this. We feel that this blue part needs to be taken care of as well, mainly for obsessive compulsive patients. This lesion is not enough for capsulotomy. This is a slide that Dr. Adler presented in this webinar. I took it because he did a great job, a financial job. He has a financial mind, right? Has developed devices that has costed millions, and he understands this way better than I'm that poor Brazilian guy. But here we go. Addiction. This is the money that we spend on this. Why we cannot take a bit of this? We just invest in a technology that can treat these diseases. These are functional diseases, and that we can help with a proper radiosurgery device. Parkinson's disease, movement disorders. We have had hard time with radiosurgery on these just because this is a complex disease. With tremor, this is a bit better. Right, and it's a very frequent problem. The prevalence is very high in the population, but people learn over the years to live with this and suffer over the years. We can really improve their quality of life with radiosurgery without major problems. So you see that the frequency of this Parkinson's are here in the third round, dystonia. These are diseases that we have had hard time because FTN is the target and globus pallidus is the target. So this is quite difficult to treat because of the vasculature and the location of the targets. We need better collimators, 2mm collimators, 3mm collimators to approach this disease appropriately. Parkinson is very common in hospitals. Dystonia tremor, which is the most frequent, is very little in comparing with the other ones, and this is the prevalence of these diseases admitted to hospitals. A bit of anatomy, we improved immensely with the anatomy that we have. This is the pyramidal tract. We are doing a palamotomy here with Gamma knife, so with radiosurgery. So here we are using this information to move our target 1.5 mm more medial, so 1.5 mm. I saw in that first slide I showed to you a lesion in the internal capsule right here, that lesion. So we have to move out a little bit, we have to move up a little bit when we are using radiosurgery to treat tremor. This is one of our fellows. And here is what you can do with this patient. This is a patient with her son, that's a doctor, both of them very happy with the results that she will end up having. Here is she's 3 weeks after. There's dancing carnival in Rio in February. Here she is now in the pandemic. This is another person that we can touch with functional neurosurgery. She has a pacemaker. We need to get to this point without having to operate the patient. You know, this was a lot of money that was spent from this family because of the technology. Depression, this is a nurse that is telling you that indeed she improved. The quality of life is different. Here we implanted a stimulator in her trigeminal nerve. So this is a simple surgery to do, but to change completely the life of that person. There are plenty of targets of radiosurgery being developed in the brain for such as the VTA, the area 25, the cingulum, the capsule. All those are possible targets that we can use in radiosurgery to improve depression. So studies like this are common in the literature, just showing that radiosurgery is at least 10 times less expensive than when you do a microsurgery in general. When you admit the patient to the hospital and you put them in the ICU, then you don't know where the price goes. So when you don't put the patient in the hospital, you treat him as an outpatient, the price is controllable. So it's important that the insurance companies understand that, they focus into the diseases that can be treated without needing an operation. The idea of functional radiosurgery is not to destroy. This is the traditional concept of using radiation. We want to modify this molecule, novel concept that manipulate. This is a DNA surgery. We can call this a DNA surgery instead of a traditional surgery with a knife. Many diseases, we know that changing functions of ion channels, changing functions of hormones, dealing with metabolism, all this with the vasculature. So we can deal with all these diseases with as we learn about the genome, and radiogenomic is a study that is going forward to help us with this study. Electricity is the solution for everything? Obviously not. You know, people use these, but they would not like to use these. How do you take a shower with getting water inside of this? So this is not the reality. This is fiction. You know, this is reality. We are with exhaustion of medication. Medication has side effects, go to the whole body, and we need to understand the genome. We need to understand better how can we use radiosurgery to modify function. Anatomy indeed improve, right? Before we used to do horseradish peroxidase in animals. Here when I was a young fellow, more than 30 years ago, and we were trying to find, if I inject here, where does it go? It goes, this is the four-way bundle, and we are getting all the way to the very important areas dealing with OCD, dealing with aggression. So this is the orbitofrontal cortex mesial. So tractography now shows us this in the human. So this is something that we don't need to do anymore in the animal, because we can see very nicely in the tractography. You see the wiring of the brain. This is improving. Every month we see a better imaging here. We are treating pain. This is the periaqueductal gray. And then we have a thalamic lesion here. The patient had a stroke. So our fellows are dividing the medial lemniscus, the lateral lemniscus, and they're showing to us the dentatorubral-thalamic tract. They're showing us the pyramidal tract. So it's really amazing what we are getting, and we need to have that information because we don't have electrophysiology when we do functional neurosurgery, right? This is not. This is the patient that cannot use her hands, and it was benefited by functional radiosurgery. It's an old lady that definitely would have a hard time with the surgery. This is now 10 years old. We are already seeing the VIM at that time, where we have to put a radiosurgery modification of a group of cells in the ventral intermediate nucleus of the thalamus. So this is with anisotropy, and this is the base of calculation of all the fiber tracking, and we can use that anisotropy to start to see very nicely. This is not of our group, it's another group, but we are seeing here our fellows that are working on this, trying to dissect these tracts in the brain. Here we have, for instance, now to treat pain, the posterior, ventral posterior nucleus of the thalamus, the anterior. Here is more the face, here is more the leg. So we are treating a patient with pain in the whole body because there is a stroke. Right? The post-stroke pain is the pain without solution. You have to find one, and the stimulation is one of them. Hypothalamus. How can we use a 4mm collimator when we have different functions? We have sleep, we have all the hormonal control of our bodies in this 4mm group of cells. So we cannot just focus here a 4mm collimator. We need a 1, a 2mm collimator. We need a fine machine to approach this. Now, electrodes, this is a huge post that we are putting inside of the hypothalamus. We stimulate a very large lesions, very large areas. So we have here the young guys trying to understand this. This is Dan Barbosa and Tiago Paranios. They are studying. He is now in Stanford, and Tiago is trying to get there and works with us in our laboratory. And you see here really the anatomy that you need. And here the Germans, Andreas Horn, presented in the think tank of DBS recently. You see that we are really starting to immerse inside of the brain and trying to understand that. Why? Because we have disorders such as anorexia with a 15% mortality. This is a bad disease. We can cure this with radiosurgery. It's done in China by the Dr. Bomin Sun from one of our fellows. Obesity, we have put a lot of effort on this. We can treat PTSD, autism, severe autism, self-aggression, difficult patients. The families suffer immensely. They hide these patients. There are many patients with this. They are appearing more and more, and we can treat by focusing radiosurgery, modulating these areas. This is the basal nucleus, lateral of the amygdala. That's where we are implanting electrodes for PTSD, and we can modulate this radiation. What about Alzheimer's disease? Can we treat Alzheimer's by stimulating areas, as I showed to you? Can we stimulate choline in this region in the basonucleus main heart, irradiating with a proper dose, like I showed to you, you can do with L-DOPA. Well, the treatment of anorexia nervosa, Dr. Bomin Sun was one of our fellows, and he has done a marvelous job in China treating patients with psychiatric diseases. He had a psychiatric training previously and came to China to do that. We have written here a chapter on radiosurgery for psychiatric diseases if you want to learn this with more in depth. Well, again, we can influence from outside the peripheral nerves. You don't need to go with this type of implants that I showed to you. There is a huge movement in treating diseases from outside. We are talking here about magnetic stimulation. We are talking about the stimulation of even the old ECT is a way of pushing energy inside of the brain and treating depression. So this is a reality, and less invasive and radiosurgery is the less invasive way we can treat diseases inside of the brain at this point. Even the HIFU, we have to shave the patient's head. This is non-invasive, yes, but it has a touch in the people's life that radiosurgery usually doesn't have. Serotonin, tyrosine hydroxylase, and we can almost conclude here, right? Is this the future? Can we modify diseases with radiomodulation? Yes, we can. We are doing this as we speak. We are not understanding this quite well, but we are already. We don't understand every measure in medicine very well. Steroids until today, one of the major medications, we still don't know very well how it works. What is the mechanism? This is what we are trying to learn. We can change cells to produce neurotransmitters. Yes, we can with energy. Why patients can stop taking L-DOPA? Just because of this. We are doing something with these neurotransmitters that we need to dissect better. So we are poised to modify circuits, induce neurotransmission better, prune excessive pathways, for instance, in the case of autism, arouse a group of cells that are dormant in the case of Alzheimer's, for instance. We need resources to do this research. We have people wanting to study. This is our group, the neuroscience group, encompassing several states in the country, neurologists, psychiatrists, neurosurgeons, obviously more neurosurgeons because we are putting these people together to improve quality of life of our patients. Thank you very much.